Dear colleagues, it's a great pleasure to give a talk at UZOBI. My topic is going to be the radiologist's expectations for help from AI, artificial intelligence, when reading mammograms. As you know it very well, the development of low-dose film screen mammography in the mid-70s made it possible for us to find breast cancer in their non-palpable early phase. And we created a revolution, a paradigm shift. For thousands and thousands of years, women brought the physician's attention to these kind of cancers. But then physicians could not control the disease. The new emphasis is on trying to arrest the process on the way to become an advanced cancer. We arrest the disease progression to advanced stage through early detection. And then very strict randomized control trials have been carried out and proved that detection of breast cancer and treatment in early phase significantly decreases mortality from the disease. But then we encountered problems, and I'm going to mention you the two obstacles hindering control of breast cancer through early detection. One of them was the lack of uniformly high image quality. The discrepancy in image quality reached unacceptable extremes. The consequences of one of the most infamous examples still haunt us. The Toronto trial had the worst image quality I've ever experienced as an external reviewer of the 50 selected cases. But during the same years, the Swedish two-county trial had excellent image quality that enabled the trial to succeed with a significantly decreased mortality from breast cancer. The large number of missed cases plagued the revolutionary new method all over the world and actually risked its survival. But the development and the introduction of full-field digital mammography removed this major roadblock. Today, the image quality is good to excellent throughout the world where full-field digital mammography is used. The other obstacle hindering control of breast cancer through early detection is unfortunately still with us. The lack of uniformly high mammography reading skills among radiologists. There is a potential solution in sight. The development of artificial intelligence gives hope that we can overcome the second roadblock. But we have to assess the performance of AI correctly. I would very much like to call your attention to the following Ant Mini article and to the two linked videos at the end of the article. This is the improper way of viewing a mammogram. This results in information overload. Colleagues are putting up the current MLO, the current CC projections, and then the previous, and the previous. This is not the way of viewing a mammogram. It leads to guaranteed failure. You are going to miss cancers. How to view a mammogram? Skilled radiologists follow reading protocols which include enlarging every mammogram and, if necessary, adjusting window setting. Let me demonstrate this on a video. You are not reading mammograms like this. Please don't do that. Let's enlarge it. Let's use all that beautiful large area on your monitor so the skin is nearly touching the edge of the monitor. And then we are using the side-by-side and step-by-step viewing. You're looking at the axilla, you're looking at the contour, the Milky Way, and then when you enlarge it properly, then you find calcifications you haven't seen before. On the CC projection, once again, we are enlarging it. And in the medial half of the breast, suddenly the microcalcifications show up, and we know that this patient needs to be called back because of a high suspicion for malignant type calcifications. But my comment is that AI must perform at least as well as skilled radiologists who follow the reading protocol described and demonstrated on video. I'm going to demonstrate you cases using one of the many AI companies' products. Look at the remarkable large training dataset. And also read the published clinical trials that used their method. Here's the first example. And this is going to be a good test for you as well. 53-year-old asymptomatic woman screening examination. Very nicely positioned MLO projections and CC projections. Please test yourself. Look at these mammograms, spend a few seconds, and answer yourself the question, would you call her back? It may be normal. It may have carcinoma. And now you made your choice, right or left breast, and then we are going to ask AI. And it very determined points out this region in the upper outer quadrant of the right breast. What I want to say to you is that the companies that produce artificial intelligence solutions should not compare their tool with this kind of radiologist, because then it's going to be easy to get good statistics. Why not compare with this radiologist who is going to find the cancer? And then AI is going to get a challenge to show its superiority against this radiologist. CC projection. Many radiologists are missing the carcinoma. AI didn't, but this radiologist could find it. Radiologists, you should never view a mammogram without enlargement. Still, AI is going to be a great help. Unfortunately, she had lymph node metastasis. So the radiologist who does not have AI or does not enlarge the image is going to miss an already metastatic carcinoma. MR confirms that there are 3 cancer foci, and here is a comparison between MR finding and the artificial intelligence tool finding. The radiology finding we compare with large format thin section histology, and here is the second carcinoma marked by the pathologist, and here is the third carcinoma. We have acinar adenocarcinoma of the breast measuring 15 by 15, 7 by 6, and 4 by 4 millimeter. Unfortunately, she had lymph node metastasis. My second comment is to the researchers and developers of AI is that breast cancer is a heterogeneous disease. And therefore, we don't like when the AI articles are talking about general sensitivity and general specificity. Please show the strengths and weaknesses of your algorithms for each breast cancer subtype, classified according to the site of origin. Most of the breast cancers, about 75% of them, originate from the acini in the lobule, and therefore we call them acinar adenocarcinoma of the breast. And on the mammogram, these are the circular and the stellate carcinomas. Together with the grade 1 and grade 2 cancer in situ forms, they account for about 75% of all cancers. When the carcinoma originates from the major lactiferous ducts, most of the calcifications are going to be long and branching. This should not be a challenge for artificial intelligence. However, my question is, when we look at this spider's web-like architectural distortion, that's where I have a great question mark. AI companies, can you find this potentially killing cancer? Because fatality rate is about 40% here, and we cannot control it by using conventional full-field digital mammography and the currently available therapeutic regimens. And when concerning the AABs, we should answer the question, what percentage of the AABs, stellate circular lesions, will be detected in fatty and dense breast tissue? Please make evaluation and assessment according to modern precision-type medicine evaluation. Show the strengths and weaknesses in every subgroup. The radiologists using full-field digital mammography did a very good job on most of the acinar adenocarcinoma of the breast because we were stealing time from the cancer. We found it when it was non-palpable. We cut back on the advanced cancer rate, and as you see, mortality is decreasing. What we really want to call the AI people's attention on, that this stem cell and this stem cell carcinoma not very controllable today. During the past 40 plus years, we could move these curves up. Our expectation is that perhaps with the help of AI, we are going to find it 1.5 to 3 years earlier, both of them. Let's look at the case of the 64-year-old asymptomatic woman, mammography screening case, fatty replaced. The radiologist gave her a well letter. However, AI would have asked the radiologist, please call this patient back. There are some areas of interest. Unfortunately, she wasn't called back. And next time, we found out that AI was correct. You see the ever-growing multifocal lesions, ill-defined tumors, extensive, and of course AI is very positive at this time point. After ultrasound-guided core biopsy, the diagnosis is established. And then we look at the extent of the disease by performing MR, just like on a mammogram, it's very extensive. And mastectomy was performed, and here we have the specimen slices. We are talking about multifocal invasive carcinoma, and the sad thing is that the radiologist passed by these small, very subtle foci, and so there was a delay in the diagnosis, which resulted in lymph vessel invasion. AI was correct to point out already at the previous examination that this patient has to be called back. What about a case where the cancer is hidden in the dense fibrous tissue? A 62-year-old, once again asymptomatic screening case. Quite surprising that at this age she has such a dense breast. This is what we are facing. And just imagine that this case is mixed in among 100 cases you have to read. Would AI help in this case? Let me look at this MLO projection again. CC projection. Artificial intelligence very elegantly points out a region in the central portion of the left breast. You might be a Hawkeye and say, it's here. Indeed, it is there. But what about enlargement? That shows it. So AI was very helpful in this case, and it was very helpful in the fatty replaced breast as well. Every single case with dense breast should be examined with ABUS. And ABUS has its AI. It's called QView. Handheld ultrasound, malignant lesion, ultrasound-guided core biopsy proves the obvious invasive breast cancer. Extent of the disease, according to MR and ultrasound, it's unifocal, smaller than 10 millimeter. And now we understand why the radiologist had a problem, because the carcinoma was so much hidden in the surrounding fibrous tissue. Smaller than 10 millimeter solitary, well-differentiated carcinoma, node negative, no LVIs. This is exactly when we want to find the cancers. Let's look at the next group when the cancer is originating from the major lactiferous duct. DAB, as we call it, cancer of ductal origin, has 6 mammographic or clinical presentations, and they should be very easy target for the AI. This one is a galactography and MR case. This is architectural distortion. That can be a challenge. 59-year-old asymptomatic woman, this is what we are looking for, that AI is going to help us finding this before the radiologist finds it. Let's look at the case. In 12% of all women, we see these large terminal ductal lobule units, which means that there are at least 100 acini, and that's a high-risk case. Adenosis pattern. On our classification scale, this is pattern 4. We don't see any architectural distortion. We don't see tumor mass. This patient got a well letter. However, AI points out an area that is worthwhile looking at. But unfortunately, at that time, we didn't have the AI. Retrospectively, we enlarge this region, and we see these beautiful pearl necklace-like calcifications. Unfortunately, it was missed. This is a typical DAB, and we know in DAB that within 2 years, there will be a lot of more calcifications, long, branching, and here it is. Let me magnify it again. This is microfocus magnification, and here we got exactly what we expected. A large region also here is full of malignant type calcifications. In this particular case, AI could have found a lesion 2 years earlier, and she would have been treated very differently, and probably her outcome would have been much better. This is duct-forming invasive carcinoma. Fatality rate is about 30% in these cases when you have this imaging marker right in front of you. AI is all over the pathologic lobe. We have to read the MR as extensive, localized to one lobe, diffuse non-mass enhancement, and we are going to prove it with core biopsy or stereotactic biopsy, typical case of neoduct genesis. This is not a normal duct with side branches, with lymphocytic infiltration, with desmoplastic reaction. This is an invasive process. And unfortunately, quite many ducts, although they are already drilling a side branch, there is hardly any calcification. It's a 6 centimeter region with grade 3 duct-forming invasive carcinoma, neoduct genesis. What is left to talk about is the cancer that accounts for about 5 to 8% of all the breast cancers. However, the fatality rate is about 40%. And it's a double trouble. Partly it's very difficult to find, although it's about 10 centimeter. Huge architectural distortion. Born big. The main feature of this disease is the excess amount of fibrous tissue. Mammography very often misses these cancers. Would AI help us to find this earlier? I'm not asking that AI should find it when it's smaller. There is no small in this one. It's large from the beginning. 40% die regardless of our regular screening and regardless of using modern therapeutic regimens. There are only two hopes, namely that pharmaceutical industry works out a custom-tailored chemical, which I doubt because there is no incentive. There are too few cases. And the other one is that we find them earlier. Here it is the presence of lymph node metastasis or distant metastasis that makes the prognosis much worse. Everything, dear colleagues, you see here is carcinoma. My note for the AI engineers, please keep an eye on this. In my personal experience, you find some of them, you miss quite many of them. Kind of a hit and miss. Should not be. This is a killer. Just imagine that every single radiopaque density here is carcinoma. Would AI help us finding this earlier? I can show you one case. She came to screening and she got a well letter. But 6 months later, she came with a palpable tumor. This was the previous examination, that is, 6 months before diagnosis and treatment. Is there any radiologist here who could find calcifications, tumor mass, architectural distortion? I don't think so. But AI did. I don't know why, but it pointed out, please call her back. Now that didn't happen. So now she comes with a huge, diffusely invasive carcinoma with metastasis, hardly visible on the mammogram. However, it's a considerable asymmetric density with some architectural distortion. And AI, once again, is all over it. Obviously, it's an invasive carcinoma. And these are the pathologic axillary lymph nodes, easy to harvest malignant cells. And when we look at the MR, we see the very extensive disease, the stasis, and the patient is on downhill. Mastectomy didn't help her. Here is once again the beautiful correlation between mastectomy specimen slice radiographs as well as large section histopathology. This is the only way that radiologists are going to understand the underlying histopathology, and the pathologists are going to understand our capabilities and limitations, the excess amount of fibrous tissue. Unfortunately, in this case, there was double trouble. Here it is a DAB, cancer of ductal origin, as well as breast cancer of mesenchymal origin. Now, these two always end up in a very poor outcome. The disease extent is more than 10 centimeter, high proliferation index, many surgically removed nodes are positive, and unfortunately the patient died 1 year after treatment. If you were able to help us in finding one stem cell carcinoma and the other stem cell carcinoma earlier, then it would be a great, great gain. My conclusion is artificial intelligence is a promising solution, and I would very much like to encourage radiologists. Don't be afraid. You're not going to lose your job. You should welcome AI with open arms. It might be the solution we need to bring the reading skills of the radiologist to a consistently high level, as it happened earlier with image quality. Thank you very much for your attention.